Yes, madam.
Yes, sir. So first of all, thank you so much for giving this your time. Your busy schedule is there, and sir, you have given us for sharing your thoughts on specifically for constipation in a pregnant woman and how it will be managed in that. So thank you once again, and thank you so much for all the invitee who is joining us. First of all, very welcome to Dr. Manish Pandya. Is a professor and HOD of Scientific Research Institute and Mavir Hospital, Manish IVF Center, and Sai Baba USC Center. A doctor has the special awards and achievements which having dynamic Indian of the millennium by AG Foundation, Gynec Excellence Award by Foxy in 2020, and commendable editor in chief by IESRF in 2021, an icon of the gynecology in the world in 2024. So this is a new, your achievements in that. So, sir, once again, congratulations for that. That you have the icon of the gynecology in the world in 2024. And sir, total, sir, you having like
118 papers.
And
118 papers.
18 papers, sir, you have done. So it's a very commendable, means, sir, what we say that it's a very achievable number is that. Apart from that, sir, from publication is also there, and sir, you have done like means in your under you have passed around 53 residents, and 4 are right now doing as a residency, and this is an ARCH recognized BGO, DCH, DRCH, DFA. 3 seats are there. Foxy recognized ART, IVF, ICSI, and USG training, 2D, 3D, 4D, and color Doppler, ICOG fellowship in reproductive medicines and laparoscopy. Here there are 2 seats and 1 reproductive fellow pass and 2 endoscopy fellowship doing at present. Sir has a very fantastic publication, like 8 book by the JP publication, 3 chapters in postgraduate series by the BI publication, 1 chapter on DUP by elsewhere publication, 1 chapter on microfluids in advanced ART textbook, total 66. 51 paper in IJOR and 5 paper in IJB, CP, 3 paper in OA, JG. So, sir, maybe 2 paper in IJMSPH and 2 paper in IJRCOG internationally. So 762 presentation as a faculty in conference and webinar. So, sir, I think that this is our first introduction which I have seen right now, and congratulations, sir, for your all the achievements, and sir, this is your platform. Please share your experience with invite, and if any have any questions, please share. Free feel to connect with the sir, and please share in the chat box also. Thank you, sir. Thank you so much once again, and sir, over to you, sir.
Thank you very much, madam, for kind introduction. Those who want to scan these 2 QR code, one is of Orchid, in which I have got 118 publications over there, and this is my YouTube video. And from Abbott side, madam, you will be surprised that this is my 127th Abbott webinar and CME DGM since last 2004. I am working as a KOL in Abbott. So today we are going to discuss something regarding the management in GI disorder and constipation for OB and GY update. Welcome to Abbott webinar. The moment child is born, mother is also born. She is there, mother is something new, said by Rajnish Ji. With the blessings of mother on mine, 3 books written by me is recommended in Royal College as a reading material. Atlas of Fetal Echocardiography and textbook of IVF Made Easy gone for 2nd edition. I am editor-in-chief of Indian Journal of Obstetrics and Gynecological Research. Anybody wants to publish their work, they can come and they can publish their work over here. I am also associate editor in Open Access Journal in Gynecology. In last ASHRE Copenhagen, I am fortunate to take interview of Professor Herman Tourne, and it is available on my YouTube channel Manish 4269 with more than 176 presentation till date. You can see all this presentation on Manish 4269 channel. So today we are going to discuss something regarding hyperemesis gravidarum. It is what we call it is a hyperemesis gravidarum. First and for all, it is the condition in which patient is not able to take anything from the mouth. Okay, so persistent and excessive vomiting is caused because of hyperemesis gravidarum. Common symptoms include intractable nausea, vomiting, inability to maintain food and fluid intake. Usually symptoms generally develop around 6 to 8 weeks of gestation, and believe me, these symptoms are very good. There is a one joke occurring in Gujarat that one of the mother-in-law had asked and done telephone to the son who is living in USA. Mother asked, how she is fine? Son says, yes, mommy, honey is okay. Mother said, honey is okay. Okay means in Gujarati it is vomiting. So she feels that her daughter-in-law has got pregnant. So there is a one very good notion that when somebody vomits with miss the period, so when Mrs. miss the period, it is a good news. So in a good news movie, I am happy to participate with my all ultrasound. And you can see the all ultrasound which is done on Kareena Kapoor was from my center, Mahavir Hospital. And you can see my name as a Manish Sushikumar Pandya in the front and back as well as in the last in good news. So what happens in hyperemesis gravidarum? Ptylism, patylism, psychology, poesophagus. This is the P is silent, so it is ptylism, more salivation, heighten the sense of smell, weight loss, electrolyte imbalance such as hypokalemia and hyponatremia, and ultimately it will cause dehydration. Sometimes elevated serum aminoesterase levels may be seen, possibly due to starvation, which generally returns to normal with successive treatment. Because of excessive vomiting, there may be mild hepatic impairment may be observed. Sometimes it is that much crucial that patients are thinking because of suicidal intention. I have seen patient who has came to terminate the pregnancy because of hyperemesis gravidarum. It is almost affecting 7% of affected women. They want to terminate the pregnancy. Increased risk of neurovascular delay and autism spectrum disorder in children, women affected by hyperemesis gravidarum. What are the symptoms? Mild nausea and vomiting. India, we all know that ginger is very good, and there are 2 or 3 companies who are marketing their tablet with ginger. Vitamin B6 and sometimes acupuncture is also helpful in the symptoms of first trimester. Initial therapy of hyperemesis gravidarum in UK, they are started with antihistaminics and thiazide. US guideline recommends that doxylamine and vitamin B6 are the ultimate solution that will give the release, and there are plenty of different solutions available in market with doxylamine, vitamin C, OD dose, BD dose, 2 tablet BD. There are sustained release tablet. What is the first line of drug? Additional therapy with flucloperazine, metoclopramide, and ondansetron, and nowadays granisetron. They all are helpful. We all know that metoclopramide may cause extrapyramidal side effect and should be stopped immediately if they occur. So few patients, they have got this perinome or metoclopramide sensitivity with uprolling of eye movement, eyeballs, and extrapyramidal side effect. So we have to stop. Otherwise, it is a very good drug because it has got prokinetic effect, and with that prokinetic effect, gut motility is increased. So less part is there in the stomach. First thing we have to understand why there is vomiting. When a woman exposed to pregnancy, she is not only exposed to pregnancy, is exposed to human chorionic gonadotropin. And human chorionic gonadotropin is notorious, and it gives a vomiting sensation to the woman. It will decrease the gut motility because of the hormone relaxing. That relaxin hormone is usually relaxing the gut motility. That's why they are complaining of constipation, stomach heaviness, even though they had desire to eat, but not able to take the food. So refractory hyperemesis gravidarum is unable to maintain hydration and weight, and for that, in some types of the patient, we have to give corticosteroid, but that is the last resort. If we have to admit the patient with prolonged vomiting, because we know that because of the prolongation of vomiting, there is thiamine supplementation we have to give to our patients. We have to give them rehydration, potassium chloride for electrolyte imbalance. Because of excessive vomiting, there may be hyponatremia. It should be corrected with normal saline. We have to give proton pump inhibitors. Nowadays, we can use pantoprazole, domperidone frequently in our patient without any hesitation. There are papers, those who are saying that ranitidine, that is not good for early pregnancy, and they have got some carcinogenic effect on the kidney system or renal system. So beware that don't have to use this ranitidine or famotidine molecule, but we can use pantoprazole molecule, which is safe, little bit safe in pregnancy. But always we have to weigh the risk versus benefit ratio. Don't allow that patient to go for suicidal suggestion, and we have to give them mental health support, and that should be given by her husband with a tender, loving care, because ultimately it is the production of both party. Both hand has to contribute into this. Husband cannot become pregnant, but he can take very good care of her wife, or to nurture her mother, baby's mother, with very good tender loving care. So what are the key features in hyperemesis gravidarum? Yes. Yes. So clinical feature: protracted nausea and vomiting, onset in first trimester, weight loss, electrolyte imbalance, dehydration, tylism. Nausea may be severely debilitated, and 20% symptoms throughout the pregnancy. What is etiology? Genetic, increased risk in Paris woman. GDF5, GDS15, that is glomerular differentiation factor 50, and this is glomerular filtration rate. This is a genetic abnormality, and because of GDF15 increase in the patients, they have got hyperemesis gravidarum, and some endocrine factors like hypoandrogenism, hypothyroidism, diabetic neuropathy, molar or multifetal pregnancy, gestational like peptic ulcer with H. pylori, J obstruction, cerebral malignancy, maternal complication because of hyperemesis, electrolyte imbalance, Wernicke's encephalopathy. We had seen patient because of excessive vomiting, they have developed Wernicke's encephalopathy, thromboembolism, GERD, that is gastroesophageal reflex disorder, esophagitis, gastritis. It will affect fetus also. Nowadays we are recognizing the term that adult disease of childhood origin, neurocognitive abnormality, we are watching in the adult or in the early childhood. That may be because of the fetal nutrition deficiency of the hyperemesis gravidarum. There is IUGR. Now we are not saying it is growth restriction, it is a growth, we are not saying growth retardation, it is restriction, and sometimes there is a preterm birth also. Initially we have to correct the electrolytes, monitor the weight, up titrate the antiemetics. We can use all the antiemetics available in market. Believe me, we are using prochlorperazine, we are using pantoprazole, we are using granisetron, we are using metoclopramide, we are even using stametil, we are also using phenargan, and in all combination we have to give them. If it is severe, then we have to give them IV fluids. Nutritional support, we have to give vitamin supplementation. Usually in our treatment of nausea and vomiting, second point will be of multivitamin, that is MBI, and sometimes we have to use corticosteroid therapy for the refractory disease. And if patient is not able to take anything, we have to introduce the nasogastric tube or the rice tube, and we have to feed the baby with that. Why there is excessive vomiting, particularly in particular group of patients? We all know that pregnancy is subjected to the cholestasis of pregnancy, generally present with elevated serum aminotransferase level. Pruritus occur mainly because of the palm and sole. When patient complains, usually, sir, I have got some itching in the palm. Don't believe that they are taking God. They have the sign of getting more money. It is not more money. It is the disease which is causing pruritus. and it may be experienced in any part of the body. Generally, it is associated with a rash. And I'm fortunate that my wife is dermatologist, so usually we are taking help of her and we are excluding the dermatological condition. And after taking the blood investigation with increased aminotransferase level is there, we say that patient has got intrahepatic cholestasis of pregnancy. So typical presentation of pruritus at 32 to 34 week of gestation, and usually but is very well worse with UDLIV, that is ursodeoxycholic acid, and we are giving this patient and it gives fantastic result, particularly in the help in the intrahepatic cholestasis of pregnancy. So more commonly observed with multiple pregnancy or with IVF treatment, we don't know, but patient maybe have got the precious pregnancy and too much of tender loving care, woman with cirrhosis or post liver disease, post transplant. Now I've got few patients who have got liver transplant and they are pregnant, so we have to be very cautious and we have to give this UDLIV from the early part of their gestation to prevent intrahepatic cholestasis. It is associated with chronic hepatitis C infection, may be participated by therapeutic drugs causing bile duct injury or cholestasis such as amoxicillin and flucloxacin. But usually we are not using in India, we are using amoxicillin and amoxiclav with clavonic acid in infection. There may be exacerbation of pruritus during pregnancy in some patient with pre-existing chronic liver disease, or patient has already liver disease and they become pregnant. We have to be cautious and we have to be sure that this patient should not suffer from this. Associated with increased rate of adverse pregnancy outcomes such as preterm birth, meconium stain liquor, and fetal hypoxia, prolonged admission with the neonatal unit, and sometimes they can cause stillbirth also. Approximately 17% chance of recurrence of ICP in future pregnancy. So always ask whether you had developed this type of things in previous pregnancy. There are chances, because this is the only thing which has got more than 70% chance of recurrence. PIH has also got 30% chance or 40% chance, but intrahepatic cholestasis has got 70% chance of recurrence. So always ask in history. What is the definition of history? Study of past in light of present to have good future. So give your patient your ear. Give thou ears, that is said in Bible. Listen them carefully. They had came with something, and usually you can dig out their complaint from their history only. And usually we are taking history. We are not taking future, but we are taking history to give her very good future. So how we have to manage this intrahepatic cholestasis of pregnancy? Drug to treat the maternal pruritus, hypercholenemia, and hepatic impairment. Intervention to improve the pregnancy outcome. The Society of Maternal Fetal Medicine Consult Series recommended antenatal surveillance. That's what I am talking. Antenatal, you have to ask, but don't ask specifically. If you ask that you have got itching in the hand, they will say yes. If they say, then you have to investigate. Then when they complain, do the serum bile acid concentration, see their urine, and say that if there is urine has with some different color, that may be because of you are giving them the vitamin. Don't say that yellow coloration always give intrahepatic cholestasis, but you have to go with serum bile acid continuous monitoring, and current treatment strategies do not yield desirable result, and hence the development of better drug is imperative. Drugs available: vitamin K, that helps in patient with steatorrhea and abnormal coagulation test. The drug which I am coding about, UDCA, that is ursodeoxycholic acid, that is UDLIV 300 unit, reduces AST and ALT level, decreases the principal primary bile acid which are elevated, and reduces the risk of stillbirth and preterm labor. We can use rifampicin with ursodeoxycholic acid, that reduces the pruritus and bile acid concentration. But when you are using rifampicin, always tell the patient that your tears will be also red and your urine will be also red. So all the secretion, tears, urine, sweat become red. We can use S-adenosylmethionine, cholestyramine, and activated charcoal to improve the maternal itch and hyperkalemia. Possibility, there is very little possibility of adverse perinatal outcome, but we can use topical emollients. Usually we are giving all them topical, like aloe vera solution or that, because we have to smooth the skin, because there is a itch scratch cycle. Once she start itching, there is a itch scratch cycle, and that we have to stop. In severe cases, we have to do for the plasma exchange. that may be necessary in some of the patient with severe pruritus. It improves biochemical rearrangement because it is a high risk procedure reserved for severe patient, and treatment option has been oxygen when nothing is available. We can go for plasma exchange, and we are removing all the notorious substance or AST and ALT level from the patient's blood. Preeclampsia. Hypertensive disorder of pregnancy are leading cause of maternal death and perinatal mortality globally. But believe me, with increased treatment, nowadays we are getting very less patient of preeclampsia. When I was resident in 1993 to 1995, we have got eclampsia room with 14 beds, and we have got so many residents, those who are coming from abroad to see the eclampsia because they had not seen. We have got 4, 5, 6 patients of eclampsia with we are tightening their hands. They are not aware. They are in aura. They have got tonic-clonic convulsion. We are giving Maxal full loading dose. If not controlled, we are also giving phenobarbital. If not controlled, we are not giving diphenylhydroquinone. So we have got great experience of preeclampsia. But nowadays, with very effective treatment and drugs availability in the market, at that time we have got very few drugs. Those we can be used safely in pregnancy. But nowadays we have got labetalol, which is alpha and selective beta agonist beta blocker that we are using in pregnancy, and highest dose, that is 1200 gram, we can use in our patient. And I am fortunate that in 2012 when this drug came in market, labetalol, at that time we had done study of labetalol comparing methyl dopa and nifedipine. But nowadays methyl dopa is not that much available in India because of it is in DPCO. It is a centrally acting drug. It will take time. Nifedipine is very fast acting drug. But believe me, if you are comparing all these three, labetalol has got very good efficacy and effect in controlling the blood pressure. So if blood pressure is controlled, there is no eclampsia, there is no preeclampsia. But what is preeclampsia? Along with eclampsia, accounts for 25% of serious maternal complication, including death. We have seen death in eclampsia when we are in resident, but when I started in medical college in 2000 to 2015, we got so much of eclampsia in our tertiary care unit, and one of the indication of cesarean section we are including in our list, that is womb primary with eclampsia, no cervical dilatation and live baby. Believe me, after having including this indication as an emergency in eclampsia patient, the turnout morbidity rate and mortality rate has gone very down. We had saved so many babies and so many mother, because here the cause of eclampsia is baby. So remove the cause. That is the notion of allopathy practice. So we are removing baby from the uterus and all the system, including we had seen the patient, those who are blind because of eclampsia, those patients with pressed posterior reversible encephalopathy. There are patients with Coca-Cola urine, that is uremic syndrome, and all these patients, all these changes of preeclampsia are reversible. So believe me, God is very kind to a womanhood. When He gives eclampsia to the woman, all these changes are reversible within a span of 15 days to 6 months. So what is eclampsia? Preeclampsia is defined as a new onset of hypertension with maternal organ dysfunction, that is renal. We have got albumin plus, evidence of uteroplacental dysfunction with IUGR, abnormal umbilical artery flow. We have got absent flow in umbilical artery. We have got decreased flow or notch in the uterine artery. We have got disturbed ductus flow. We have got disturbed MCA flow, and we have got disturbed aortic fundal flow. See, this all Doppler we should monitor with the patients, because we don't want stillbirth. One death in a baby, we had published paper of why fetus commit suicide in abdomen. Why fetus commit suicide? And one of the cause of suicide is uncontrolled hypertension. So if we are able to control the hypertension, so it is my earnest request to all listeners that you should measure blood pressure by standard sphygmomanometer by yourself only. Once you are in doubt, take blood pressure after 10 to 15 minutes. Still you are in doubt, take blood pressure of both the hands and start antihypertensive as early as possible, because this is the only way we can prevent preeclampsia. Hepatic dysfunction in preeclampsia is characterized by elevated AST more than ALT. Risk factor usually nulliparida. First exposure to pregnancy, multiple pregnancy, previous preeclampsia, positive family history. If sister has got preeclampsia, there are chances that the next sibling may have preeclampsia. IVF patients or maternal age and pregnancy with ART. They all have got good chances to become eclamptic or preeclamptic or hypertensive, to start antihypertensive treatment as early as possible. Hemolysis elevated, that is HELP syndrome. Usually in HELP you have to take help from your colleagues. That is hemolysis, elevated liver enzyme and low platelet. 10 to 20% of patients with preeclampsia develops HELP, characterized by hemolytic anemia, increased liver enzyme and low platelet, considered as incomplete syndrome on 1 to 2% elements are patient. Symptoms include severe headache, blurred vision, epigastric or right upper quadrant pain, that is because of there is Gleason capsule up in the liver. This is a liver which is situated in the right hypochondrium, and stretching of this Gleason capsule causing upper right quadrant pain associated with nausea and vomiting, sudden swelling in the face, and presentation may be atypical. Patient have got aura. Late diagnosis has got poor outcome, because we all know with if control have, patient can go in BIC. So this is HELP. In HELP syndrome, we have got immunological factor that also occurring here. Immunological factors, genetic factors, environmental factors. Decreased uteroplacental blood flow causes ischemia, that cause increased placental oxidative stress. Imbalance of anti-ento pro angiogenic factor and endothelial dysfunction causes PIGF, and SFIT1 that cause placental dysfunction, causing circulatory disturbances, causing hypertension, cardiac remodeling, proteinuria and acute kidney insult. In CNS, that is causing headache, hyperreflexia, visual response, that is blurring of vision and causing eclampsia. Liver, RUQ pain, that is right upper quadrant pain, HELP syndrome, subcapsular hematoma and hepatic impact, and sometimes it can go for rupture, and if it is uncontrolled, it can go for hemorrhagic and HELP and DIC. It also causes difficulty in babies, fetal complications like IUGR, oligohydramnios, placental disruption, premature birth and fetal infant death. How to manage? Usually we are starting aspirin prophylaxis. Those patients have got history or maternal history, better to start aspirin, because in class study, collaborative study of low dose of aspirin, you have to give aspirin 75 to 150. At which time you have to give aspirin? That is at the bedtime, 10 o'clock, because we all know that circadian rhythm or cortisol should be given at the bedtime to get the maximum result. If there is HELP syndrome, delivery within 24 to 48 hours, because we don't want this patient to go in DIC. Usually if diagnosed early with severe preeclampsia, planned delivery. If patient has got hematoma and present to you, you have to go for intensive monitoring, aggressive management of bleeding risk and severe serial liver imaging. To control the bleeding, you have to peripheral packing, hepatic artery ligation, hepatic artery embolization. In some patients, because of the right liver hematoma or rupture, you have to go for liver transplant also. Usually with all this control with recombinant factor or FFP or cryoprecipitate or platelet, nowadays it is very well available in all blood banks. Acute fatty liver in pregnancy range from mild to moderate to severe, rapidly progressive. Maternal infant mortality parallelly with liver disease, severely disease. It is in timeline to the diagnosis, while most present in third trimester. Acute fatty liver of pregnancy usually diagnosed, or sometimes you can diagnose 23 weeks as early as possible, and 5 to 25% cases are diagnosed postnatally. It is associated with usually primipara, all multifilial pregnancy. Why male fetus dominant we don't know, or patient with low body mass index. Symptoms: preeclampsia, HELP with fatty acid oxidation. Complication include hepatic encephalopathy, acute kidney injury, pulmonary edema, GI bleeding and ascites. Postpartum hemorrhage is reported frequently in women with acute fatty liver of pregnancy. After delivery, clinical recovery is typically within 3 to 4 days. Laboratory, we usually know that AST, ALT level, decreased platelet, increased prothrombin time, bilirubin, can persist for 5 to 7 days or later. How to manage? Always give supportive care and urgent delivery of the baby. Aggressive management is required in instances of complication of liver failure, including cerebral edema, coagulopathy, hypoglycemia, and renal failure. Infection usually occurs and we have to give antibiotic. Here not prophylactic antibiotic. We have to give the therapeutic antibiotic. Management includes patients with newborn with fatty acid oxidation disorder. Patient infants are high risk of hypoketotic hypoglycemia. So we have to monitor fetus sugar level. Look for fatty liver in the baby, cardiomyopathy, progressive neuromyopathy, and sudden fetal death syndrome. Why? Fetus committing suicide after birth. That may be the cause of acute fatty liver. And believe me, again I am repeating, adult disease of childhood origin usually ask that whether your mother has got some disease while you are in utero. So management of liver disorders, hyperemesis gravidarum, treatment with PPI, intracolic cystic pregnancy, we are with ursocholic acid, preeclampsia, or help monitor an acute fatty liver of pregnancy. You have to monitor the patients and the treatment. One case scenario is that postpartum eclampsia is much more dangerous than the antepartum eclampsia. Most of the patient death are there in postpartum eclampsia patient. So don't forget to give Maxel even after cessation of last convulsion at least 24 hours. So before that, you have to see the urine output, measure and respiratory rate, and always keep ready calcium gluconate for as an antidote. GI reflux in pregnancy. GI reflux is one of the most common GI disorder with 45 to 80%. It is around 25% of pregnant women experience heartburn daily. Symptomatic gastrointestinal reflux. This is usually present in the first trimester and progresses throughout the pregnancy. Why it is there? Because of the hormone relaxing. The sphincter, gastroesophageal sphincter, usually it is constricted after food bolus goes in the stomach. Here, because of the relaxing, it's get open. We all know the stomach is full of HCl, and that HCl is coming into the esophagus. Esophagus mucosa is not supposed to exposed by this HCl. That's why they have got irritation, and that irritation causes GI reflux or GERD. Fortunately, GI reflux disease complicated during pregnancy are uncommon. Symptoms are limited to pregnancy period without long effect. Typical manifestation of GERD during pregnancy such as heartburn, regurgitation, reported, and now very good drugs available in market with alginic acids. So we can use this. These are the data of cross-sectional study of GI reflux across during the third trimester. You can see in first trimester it is 35%. Second trimester again goes to 30%, but it is 46.8 because of the gravid uterus compressing over this stomach and causes reflux esophagitis. So overall prevalence is 38.5. The prevalence of GI reflux disease in the third trimester is significantly higher than the second trimester and tends to be higher in third trimester because of the gravid uterus compressing the stomach. In pregnant women with GI reflux disease, the frequency of regurgitation is significantly higher than that of heartburn. Typical symptoms are more prevalent in daytime and compared to nighttime because patient is sleeping, and because of the sleep, there are chances that the stomach content will go easily into the intestine. So what is the prevalence of GI reflux? This is in India. These are the data from longitudinal study. 83.4% of women experience either heartburn or regurgitation. GI reflux disease is more common in primigravida compared to multigravida. 50% remain symptomatic until the term. Regurgitation is more common than heartburn. It is associated with nausea and vomiting. Women with antenatal history of GI reflux disease has 3 to 79 times chances of developing symptoms in the third trimester. Incidence of GI reflux disease decreases over the 3 trimester. These are the data from cross-sectional study. They had done study on 154 patients, and they had seen that in first trimester 46 patients, second trimester 35 patients, third trimester 73 patients, And if you see heartburn, regurgitation, everything is very well in first and last trimester compared to second trimester, because second trimester uterus become abdominal organ but it doesn't compress the stomach. So this is the pattern of heartburn from the longitudinal study. You see regurgitation is very high in first trimester as well as in the last trimester, so we should be cautious. These are the trends of nausea and vomiting. Percentage women in first trimester it is very high, same in third trimester it is very high. So in this first and third trimester we have to give them the medicine. So what is the pathology behind this? The recurrence of GI reflux disease during pregnancy is multifactorial, involves both hormonal and mechanical factors. It frequently results from progressive disease in lower esophageal sphincter pressure due to incremental increase in the circulation of estrogen and progesterone. We all know that estrogen and progesterone are required to nurture the pregnancy, and we have to thank our mother that our mother has generated enough of our progesterone, the hormones which nurture the pregnancy and the hormones which relaxes the gut. The lower esophageal sphincter pressure occurs at 36 weeks of gestation. Lowest pressure is there at 36 weeks of gestation. So you see at that time heartburn is very high. Patient usually complain that even though I am taking the little amount of food, there is heartburn. Heartburn and acid reflux are associated with severity of nausea and vomiting. Other factors may also play a part in GI reflux disease are increased intragastric pressure, secondary to enlarging uterus, changes in the GI motility because of the relaxing, through ineffective esophageal motility with prolonged clearance time. So how we should manage? Symptoms of heartburn and regurgitation have got sensitivity of 78% and specificity of 60% and can be diagnosed on the basis of two symptoms with additional testing. The presence of more severe alarming symptoms or those with might indicate underlying problems. Pregnant women should be referred to GI specialist for further investigation, and we are fortunate that we don't have to go that up to that extent. We are able to manage with management available in our department. So we are managing patients by ourselves. Usually in breastfeeding also involves this type of things. So it also occurs in postpartum period also. So we have to give them the lifestyle modification, dietary modification. Because we are living in Gujarat, we are my wife is from Jain family, and you see there is a notion in the Jain family that don't take food even after evening. That they are calling chow vihar. That is chow vihar. Chow means the person who was traveling with four legs, and chow means the birds, they are taking the chunks, that is chow. So even if you give any food to that birds and cow, they are not eating after sunset. So why you are two-leg moving person start to eat in the evening? So if you modify your life and become a Jain, then you have got very good control over this disease. You can use all available pharmacological medicine to the baby, but always have a risk versus benefit ratio. So this is a step-up protocol, how you are managing. So patient with GERD, patient or woman with typical gastrointestinal reflux with heartburn. First, I said lifestyle modification, make them Jain. Even after no response, we have to use antacid. Even after no response, we have to get sucralfate with H2 receptor blocker and antacid. If not relieved, then we have to give PPI with antacid. So many times with alarming system, we have to go for gastrointestinal rosis, but we are fortunate. Usually patient has got relief with our first, make them Jain, give them the chow vihar option, don't take any food after sunset, and you are relieved with these symptoms. What medicine we can give? Antacids, and now very good antacids available in market in form of magnesium, aluminum, calcium containing, magnesium tricyclate, sodium bicarbonate, and we have got very good alginic acid. Now we have got raft formation is there, and with that raft formation, very less antacids or very less GRD is there. So many rafts available in market. You got H2RSA. You got PPIs in form of esomeprazole, lansoprazole, dexlansoprazole, rabeprazole, pantoprazole, omeprazole. But usually we are using pantoprazole in our formulation, and we are happy to use this. So antacid in GERD we can use but it is not indicated in breast milk. So, but we have to weigh the risk versus benefit ratio. H2RA, sucral fat, PPI, PCABs. The pregnancy, the indications are unknown. So usually PCABs we are not prescribing. Metoclopramide has got some side effect, but usually we are giving metoclopramide in our patients, but we don't see any complaint in our patients. Now, last part of my talk for another 10 minutes is constipation. When I speak the word constipation, I usually remember the film pick, motion से emotion. It is very well described. A constipation, a daughter who is helping her father to relieve of constipation, and very well narrated by Amitabh Bachchan and Deepika Padukone. And I'm happy to share that I have been with Irfan Khan in Milan for 2 o'clock in night to 6 o'clock in the morning, and we have stayed together and we have got very good conversation. And at that time he was not suffering from any brain disease, but because of our communication, when he developed the brain disease, because I am doctor, he had contacted me, and at that time I told, nothing can be done for your disease. Live life king size and live happily. And that person has given so much of beautiful movies. So I always include Piku whenever I am talking about the constipation. Constipation, motion से emotion. Up to 40% of women experience constipation during pregnancy. Why? Again because of hormone relaxing. Again because of decreased gut motility. Again because of less food intake. Constipation during pregnancy increases the risk of potential disease. Constipation is not good. That's why you can see lots of advertisement in TV of constipation. पेट सफा, हर रोग दफा. Take कायम चूर्ण. हर रोग की सजा, constipation. So whenever there is pregnancy and constipation, you have to treat it. But which are the safe molecule available in constipation? Why there is constipation in women? Because of pregnancy, plus we are giving iron, insufficient fluid level because of the nausea. We all know patients are suffering from dehydration, vomiting, decreased physical activity. Women should not work. Women should not do exercise when she is pregnant. Women should not carry heavy weights. They are resting. So less of physical exercise. Loss of social trace. Hormonal changes. Again I am telling, relaxing, increased level of progesterone, decreased motion concentration. What medications? Iron preparation are used to treat anemia. Under hypertensive condition, magnesium sulfate is also commonly used. And that again growing uterus and sometimes painful hemorrhoid, piles. They are all causing constipation. So pregnant woman may develop constipation for first time in pregnancy or may experience worsening symptoms in case of history of constipation. Change in bowel function may have an impact on overall quality of life during pregnancy. In first trimester, constipation and bloating affects the quality of life. Constipation and hemorrhage are associated with negative woman's health, quality of life of childbirth. Constipation during pregnancy increases with the incidence of anorectal disease. So always believe that these patients are not good with constipation. Okay, so even with there are risk of abortions, preterm birth, other complications which endanger the safety of mother and infants. So what are the management options? First and foremost, lifestyle changes. Always tell the patient that today you have taken wheat, see that next day you have got constipation. Today you have taken bajra, next day there is constipation. Today you have taken some aloo, today you have taken some different food. Avoid the food which can causes constipation to you. We don't know your GI system. Sometimes the things which is not constipating for me, that may be constipating for a woman. So always give them the plus minus ratio, that eat one food and see that second day whether there is constipation or not. So avoid that type of food. Educate the patient. Use the environmental modification. Water consumption. Take them very good electrolytes. Take them the things which can increase the stimuli of peristalsis. Give them the zinc, give them the benefit of electrolytes. Drinking carbonic acid beverages is not recommended. Usually we see that nowadays it is a custom that we don't take anything, we take thumbs up, we take cola. That is not good. This is not meant for Indian digestive system. Always take increased dietary fiber and fluid intake to improve your symptoms. Proper exercise can speed up the intestinal peristalsis and strengthen the pelvic floor muscle. Suitable exercise during pregnancy includes swimming, walking, jogging, gymnastics, yoga, climbing stairs, Kegel exercise. Here you don't have to cite the saying Kegel hai koi nahi, Kegel hai koi nahi. Kegel is very good exercise that you are strengthening your pelvic floor musculature, and even though it is helping in your delivery because your pelvic floor muscle is very strong, you can push baby very well. Adequate sleep is always should be there. Always keep them in very good and happy mood to relieve of complication. Compared with intermittent admissions and daily regular complication of iron therapy reduces anemia, and you have to give them the constipation free iron. And nowadays iron available with sorbitol impregament or iron with sorbitol, that is also good for constipating patients. Probiotics may assist that increase the gut motility, increase the gut flora. Laxatives are recommended in dietary modification. Choice of laxatives should be that it should be effective, non-teratogenic, not excreted in breast milk if they are in postpartum period, and it should be well tolerated without any taste or without any smell. Now we have got honey based taste laxatives are also available. It should be osmotic in nature, just like lactulose. It is available in market since years together. It will increase the amount of water and colon, facilitate and peristalsis and evacuation. If fetal infection occurs, we have to give glycine enema, that is proctoglyce enema, which is recommended, and sometimes we have to give an option of finger evacuation because of so much of hard stories that we have to manually remove with our fingers. Liquid paraffin injected in case of anal fissures, but usually we are not recommending. Enemas, however, can be offered safely. It doesn't cause any effect to the baby, but we don't usually not recommended enema in during pregnancy time. When symptoms are severe and refractory to conventional measures, further diagnostic test must be recommended. What is the American guideline of 2024 on laxative usage? Constipation in pregnant person may result from hormonal, medication related, that is iron, physiological changes. Treatment option includes first is dietary fiber, most important is lactulose and polyglycerine glycol based laxatives. These both are marketed by Abbott. So constipation during pregnancy can be attributed by physiological, medication, anatomical factor because of the gravid uterus, dietary non-fibers, metabolic and hormonal changes. Increased dietary fibers, like we have to take fruits, green leafy vegetable, whole grain, legumes. We can take the sprouted beans. It is recommended daily in amount of at least 30 gram to help to promote regular bowel movement and prevent constipation. Consumption of adequate amount of fluids, particularly water, can help to soften the stool and ease bowel movement. Bulk forming agents like xylem husk, methyl cellulose, that is very good. Isabgol husk are available in India, and so many companies are marketing Isabgol husk. It is non-toxic. We cannot say it is Ayurvedic. It is a natural fiber which swells in the large intestine, and it will get very good easy evacuation. And India is proudly country that Isabgol husk are mainly produced in India. Osmotic laxatives can also be administered safely during pregnancy. Excessive fibers and osmotic laxatives like lactulose can be used, but there are chances that patient has got bloating. Stimulant laxatives should be avoided because we don't have that much of safety data. Now comes mechanism of lactulose. Lactulose is artificially synthesized disaccharides. It is an osmotic laxative and probiotic. Not digested in small intestine, that is the beauty of that molecule. In colon, it causes an osmotic gradient and promotes softening of the stool, making it easier to pass. Increase the number of intestinal probiotics such as lactobacillus and bifidobacterium, reduces the number of anaerobic bacteria and regulates the microecological balance of the intestinal tract. That's why this drug is very safe when patient has got hepatic coma. Believe me, lactulose was very much used in patients of hepatic coma or hepatic diseases or cirrhosis of liver diseases, and nowadays we know that it is a very good constipating, anti-constipating agent, and we are using in pregnancy. So lactulose commonly prescribed in China, not in China, in India also. It is US FDA approved pregnancy category B drug. It is recognized by World Gastrointestinal Organization, that is WGO, for an effect on constipation in pregnancy. Significantly improves overall stool characteristics, no serious adverse effect. High treatment efficiency, satisfactory rate, and improves quality of life of the patient. Used in postpartum, can significantly improve bowel motility, stool characteristic, shorten the hospital stay for the time of perineal distress, and it is very good post-delivery also. Because of the episiotomy, patient is suffering from pain during defecation. At that time, if we prescribe lactulose, it is very good. It does not cause blood sugar fluctuation and does not affect the nutrition absorption, even fetal development or breastfeeding. You can give it very well. And believe me, in infant also we are able to give lactulose. The role of lactulose in postpartum period, because we all know that in postpartum patient have got experience of abdominal distension, pain because of episiotomy, headache, because of new experience of motherhood, there is insomnia, emotional irritability, and loss of appetite. In severe cases of hemorrhoids or prolapse, you can use lactulose. Patient recovery from lactation is affected if the patient is physically discomfort due to complication of around constipation. Upon not receiving timely appropriate treatment, there is high possibility of developing into colonic condition affecting the pelvic floor muscle floor exercise equipment. Lactulose is harmless to the breastfeeding babies. Along with other benefits, lactulose can be given used as a probiotic to improve the microenvironment of mother GI tract. So you can use lactulose very efficiently to our patients to nurture the constipation. So safety of lactulose. This is a study conducted by Abbott in the patients of postpartum constipation. 200 patients they had done study. 100 patient has got lactulose. 100 is control. Compared to placebo, lactulose treatment group showed increased number of bowel movement per week within the first week and significant increase in the fourth week. So don't think that lactulose work instantly. You have to wait for lactulose to work in a mother. That when you give this constipation or lactulose, you have to say that you have got relief of constipation after 24 to 48 hours. It doesn't relieve constipation instantly. If they want relief of constipation instantly, give them proctoglycine enema, that is glycerin enema, or there is a finger evacuation. No adverse effect reaction. Even extend the patient who has got diarrhea with disappearance after adjusting lactulose. No liver or kidney function abnormality in the treatment group. Another patient to effect of lactulose as a probiotic in women. This aim to evaluate the probiotic used 2 gram of lactulose in defecation related factors in Japanese women. They had done study on 52 healthy women between 18 to 65 years of age. Difficulty in defecation frequency 2 to 4 times. 2 gram lactulose for 2 weeks and placebo in random control, that is double blind study. Washout period is 3 weeks. What is the result? No side effect or severe adverse effect observed in any of the participants. Improvement was seen in defecation frequency, number of defecation days, fecal volume, percentage of bifidobacteria after intervention. So it concluded that 2 gram per day lactulose significantly increases the defecation frequency of participant, possibly due to significant and selective increase in bifidobacterium numbers. These results indicate the lactulose has got probiotic effect. So thank you very much for listening this conversation of GI disorder in pregnancy. Main need is difficulties because they are necessary to enjoy the success, said by APJ Abdul Kalam. And Madam, you have mentioned the award Dynamic Indian of the Millennium. So I and APJ Abdul Kalam are sharing the same award. So I am happy to share that I am a little bit part with APJ Abdul Kalam, and we had got this award at the same time. And to take the blessing from APJ Abdul Kalam was a very good day in my life. We had done very good study on dydrogesterone, and believe me, this dydrogesterone GIF is available by so many companies. This paper was published in 2016. So at the end, everybody should be happy. तो कहते हैं ना, the time to be happy is now, and the place to be happy is here, and the way to be happy is to make someone happy and have a little heaven right here. Thank you, Abbott, for giving me opportunity 127th time to speak on this Abbott platform. Thank you very much. Thank you, Abbott. Just now I'm stop my screen sharing. Yes, madam, over to you.
Sir, first of all, yes, sir. Thank you. Thank you so much, sir, for sharing your thoughts and sharing your experience with difficulties. Thank you for giving time. Any specific questions or anything, please share in chat box. Otherwise, we will end up our meeting.
Thank you, Abbott. And I think
Thank you, sir.
I
Thank
try
you so
to.
much.
You are Sylvie Malai. So thank you, Sylvie, for giving me opportunity on this platform. And thank you very much. Good night.
Yeah,
Take very
thank you,
good
sir.
care of
Thank you
patients.
so much.
Give all the medications available for GI indications.
Yes.
And give them patients happy, because motherhood is the only thing which is experienced by mother. And Ragnishri
Yes.
always says that mother is something new. She is there. When child delivers, mother also born. When child born, mother is also born. She is there. Mother is something new. So somebody says, what is the age of my mother? I usually says it is 55. Because before that she was only Chandrika Ben. She was not mother. When I born, she become my mother. So age of my mother and me are the same. Thank you.
Same.
Thank
Right.
you.
Thank you, sir. Thank you so much, sir. Thank you so much. Thank you for giving me